Hopefully you can all hear me. So I'm Vincent Major. I am an assistant professor in population health in a center for innovation. So we do a whole variety of things to do with AI, also more broadly health technology, patient experience, clinical decision support, all sorts of things like that. And I also lead our efforts to operationalize AI into our EHR. There's a lot of very technical aspects of working with Epic, sort of how we can make scores in real time. So just sort of going to get into it. So a bit of a poll, if you could raise your hand if you currently work in the healthcare industry, which is over half. Okay, cool. What about if you have personally built a custom AI model? Okay, that's at least a quarter. That's pretty good. What about for everyone else? Have you built or bought or use AI that is in clinical practice? Okay. At least half a dozen. That's pretty good. Okay, so that's sort of our jam as a team at NYU. But just more broadly, so NYU Langone Health is an academic medical center in the New York City area. We have over 300 locations, spanning the entire area. And we're constantly expanding. We're in the middle of merging with another hospital out in Long Island. Putting some numbers on there, we have 6 inpatient locations, 4 EDs, 2,100 beds, and just shy of 200 ORs. In the last year, we've seen just shy of 10 million outpatient visits, just shy of 10,000 births, 70,000 discharges, 180,000 ED visits, and our Epic system has just under 8 million unique patients in it. We have a lot of very great scientists and faculty. We are number 2 medical school for research, number 3 hospital in the country. And from the technology IT side, we have a lot of recognition and honors from Vincent and Leapfrog and Magnet. We really have embraced IT 5-8 years ago, and it's really impacting everything we do. Okay, so I'm a trained engineer by practice, followed in some of my family's footsteps, but I've been working in healthcare for 9 years. I got my PhD at NYU in biomedical informatics, where I developed some custom AI models to identify hospitalized patients who are at very high risk of dying in the next 2 months. And what is pretty unique for the average PhD student is I also deployed these into our EHR to notify physicians within a median of 3 minutes of admission. I wear 2 hats, academic and operations, and really the majority of our work is focusing on the bottom right of this graph here, which is while there's a lot of research of AI in medicine, a tiny, tiny fraction actually makes it implemented in clinical practice. So the predictive analytics unit at NYU has existed for about 7 years. A guy named Yinapin Yanafongs is the director. And so the purpose of the PAU at NYU is really primarily to provide a predictive modeling capacity to increase efficiency, drive value, and translate AI to the point of care. We also actually lead these projects from development, implementation, and evaluation. We also do some educational and professional development stuff, and we also provide a central sort of umbrella organization to the institution's efforts for clinical data science. So an example of this, which really ties everything together, I'll talk about this more in detail later on, is that with COVID, New York City really experienced surge conditions really early in March 2020, and the team sprang into action and actually in only a couple of days assembled initial data set of labs, vitals, patient outcomes, and only another day or 2 to actually have a prototype model of favorable outcomes. These are good patients that are going to have relatively good outcomes as opposed to many of their peers. By week 4, we could actually deploy this in the EHR in Epic's cloud platform called Nebula. And a couple more weeks to refine things, do some more clinical validation, and then we could actually integrate it, build the records out to allow physicians and nurses, care managers, et cetera, to actually see these scores in their practice. And by week 8, we actually started an evaluation of this model in a randomized controlled trial. We've also shared this model with other sites, which to my knowledge is the first AI model shared through Epic's App Orchard for free at least, which is really cool. We've had a couple of people actually take the model and basically unpack it in their org. So the big picture of clinical predictive models, as I see it, is that a good model does not guarantee success. We actually need to consider the entire workflow, particularly things like timing. Can we get the data that we want to use at a time in which it's meaningful to make that score? So there's a few hurdles to this. The first is model performance. Often we will actually take a slightly less complicated, lower performing model because of its practical considerations. The next hurdle is the reach of your notification. Who are you telling, and when, and how? The next is how likely is that person to actually listen to you? And then the fourth is even if the user decides to act, how effective is the treatment in actually changing anything for the patient? So only if you get over all of those hurdles may you see any impact. So I think about this as sort of stages in what we think about, prediction, communication, the decision at hand, if it's one intervention or multiple, how effective is the intervention, and then finally you get to the evaluation piece, which is intentionally going off screen because it's never actually done. So the next chapter, as I see it for AI in healthcare, is really about getting this into typical clinical workflows. And thankfully in biomedicine we have an existing pathway to this, translational research. There's this kind of a staged approach where you have fundamental or basic sciences, finding mechanisms of action, things like that. And that is translated through clinical trials, phase 1s, phase 2s and 3s, to you're actually starting to see how this works in humans at scale. Right? The next step of that is, okay, once you maybe have FDA approval, you're actually allowing this drug to be prescribed, and you're no longer in the carefully controlled limits of an RCT. You're starting to see physicians choose one drug over another, and that's where you're actually seeing the real meaningful impact. You're studying the population, not an individual. So I think in AI, we think about some of the model validations, things like that, but we often jump straight to letting it be used by physicians or any other users right at the end. We don't often stagger it like this. So I think most of the industry is about halfway through this stage. A notable example of an area that's gone much further is something like diabetic retinopathy, where there's many, many, many more steps than you'd think to actually get this to be used. So even once after you have independent validation of the AI, that's the second piece, you then have to have regulatory approvals, right? You then need the infrastructure to run this thing. You then need some way of documenting that you used the system. In this case, a CPT code. It was created just to use the system. Then you need clinical guidelines, basically the acceptance of the medical community to use the system. And then you need the approval of all the major payers that you'll be reimbursed to use this. And then finally, you actually need those boots on the ground physicians actually doing the work using the system. So how we think about finding value with our AI at NYU is really, many of you maybe have seen this, is initially the triple aim. It's now the quadruple aim. So thinking about better outcomes for our patients, thinking about reducing cost per capita, thinking about improving the patient's experience of care, so not waiting too long, things like that, and then also improving the provider experience with the EHR, fighting burnout, fighting alert fatigue, and things like that. So I have 3 case studies which I'm going to absolutely try to race through because I think they're all interesting. So the first is pre-authorization for outpatient imaging. Now, a few other people have spoken about prior auth before, but fundamentally for outpatient CTs or MRIs, at NYU at least, we typically schedule with a 3-day buffer to allow those pre-authorization materials to be completed and the payer to get back to us, maybe one revision or two. So what we know from the data is that some payers are quicker than others, some imaging modalities are quicker than others, and sometimes an imaging is just simply not indicated for that patient. So we can use the data that we have on hand to make a model for who will be pre-authorized quickly, and we can use that to not rely on the 3-day buffer for those patients, but actually to schedule them, say, tomorrow, filling in any open slots we have on MRI machines, for example. So the data for this is referral information mostly, about the payer, about the imaging modality, the priority, billing codes, demographics, and the target here is approval before the start of the next business day, i.e., can you schedule this person for 9 o'clock tomorrow? So the models are actually fairly good. We want to use them somewhere in the high precision range, and so we have recall around 0.1. And we piloted this with a Dockerized system. This is all on-prem. So basically, SQL code is executed, the data is collected, the model is run, and then we actually push this prediction back to Epic using something called Epic Interconnect, basically a web service, where we're changing a piece of data in that referral to allow the scheduling staff to see no buffer is needed, which is actually really cool. The problem is that wasn't real time enough because lots of exams are scheduled the same day that they are referred. So we need something much more real time. So we went into Epic's cloud product called Nebula. This is what the build looks like for what it's worth. We were predicting on orders, which are basically the same as referrals. And we have to put all the data that the model needs into something called a report. And basically we batch every 15 minutes, catching new referrals, making scores, and ready to go. And so what that looks like for this is we have an MRI model different than a CT model, but one score is made for each referral, there's only one. And then it gets returned. And the real benefits of Nebula, as we see them, is that we can get real-time model scores. The model output is logged into a special place in Epic called RDI, which makes prospective validation really, really easy. It's also scalable. In busy times of the day when lots of referrals are made, it just scales up naturally. There's no maintenance of on-prem servers, which is a huge thing. There's no downtime. There's no reboots. There's no security patching. And we have out-of-the-box dashboards like this one that shows you how many scores are made per day in the last week, and also the distribution, basically the box plots of those scores. So what we found earlier this year is that by drawing a really conservative threshold, we want to be really sure that these pre-authorizations are going to be approved, we can still find 16 and 7 CTs and MRIs per day that can be scheduled tomorrow. So any last-minute cancellations, for example, where the machines would be sitting idle, not making any money, only incurring costs, we can actually fill those with these patients. Basically, those patients get to skip the queue, and they have satisfaction from that as well. So what this looks like for schedulers is basically the column on the far right. Basically, it is a green check mark for schedule ASAP, or a little calendar icon to schedule in the future. This has not quite gone live yet, although it continues to validate, partly because there's been a change in our pre-authorization workflow, so changed distributions a little bit, and we're a little hesitant to go live until we can double-check the numbers. So the next one is this COVID model that I mentioned before. And unlike a lot of other researchers, we took a different approach, which is which of our patients currently taking up a bed in the hospital could be discharged safely. So that's none of these things in the next 4 days, dying, going to hospice, needing to go to the ICU. If they are discharged, ending back up at the hospital, that's obviously bad, and also intubation or requiring any significant O2 support. So basically, we start with a model that's a black box, XGBoost or Ensemble, whatever, but we wanted to boil it down to a model with the smallest number of features that could be combined in a linear model and have pretty good performance. We do this with a variable selection process with conditional independence tests, and we get down to 16 features. So we can see here that the blue line is actually the simpler model. It's not that much worse than the complicated model, but what the good thing is we can use this in practice. We can explain what it is doing. Everything was changing so quickly early in the pandemic. We wanted to be able to explain exactly what the model was doing. And we color code these scores: green for patients are good, orange they're moderate, and red they are not. And we can explain these features, and we can also explain the individual predictions for each patient like this. And when we get to Epic, we do exactly the same thing. We color code them, and we have in the bottom of the bubble on the right, we can actually explain what the model is saying is high or low risk for that individual patient at that point in time. These scores are made every 30 minutes. And we actually, as you can see here, we have a placeholder for missing data because NAs are not understandable by the average nurse. So let's get rid of those, make them missing data. And we also have a placeholder for hidden as part of a randomized controlled trial. Again, I shared it on App Orchard. So the result of the trial, we were expecting length of stay to decrease. That was not the case. This is recently published, I think, last month. We found no safety, no issues with safety outcomes, which is great. But I think why it didn't work, I think things were just changing so much in 2020 that it wasn't really a good time to be doing this kind of, really one of the first AI in practice kind of studies. The good thing is we have some metrics from Epic about how the model was used, but we don't know who the individual people are who use it. So it was good, not great. The good thing is the model actually continued to validate even into the Delta variant in 2021, so we don't think that is to blame. And then I have 15 seconds. So just about COVID vaccine cards, we have an OCR and NER system that basically takes in patient-taken photos of cards, pulls out their information and the dose and the lot, and then we put that straight into Epic. The biggest hurdle for deployment here is how you get that data out of something called the blob store. And funny, it's a bit of a hack. We're using basically a PowerShell script to copy those documents out. I can skip these. And so really, just in summary, we're integrating AI into almost all facets of delivering healthcare at NYU. They're clinically facing, they're enterprise aligned, and they're patient-centric. And by embedding our AI team in both research and IT, we bridge the two worlds. We know what is needed, we know how to get done, and really what we try to do, growing AI beyond research into the real world. So, thanks so much.